All right, so I wrote this back in like 2019, but everything is still true. So we're gonna talk about some of the newer drugs. We've talked about hydroxyurea, and these are specifically disease modifying drugs. So we'll have another discussion later on iron overload and on iron chelator. So these are specifically the disease modifiers or DMTs. Go review pathophysiology again till you get bored of it. Talk a little bit more about the clinical manifestations and management. We're not going to really talk about transfusion. That's the wrong entry. But this is one of my favorite pathophysiology slides, not just because I created it, but it shows you an important point here, which is that the cells are fragile long before they sickle. So most red blood cells live for 120 days in our bodies. In somebody with sickle cell disease, they live between 10 and 30 days. So a lot of our SS patients especially are super skinny because they're busy making new red cells and using all their calories for that. And this is an example of the red cell hemolyzing. And it's this concept that it has to sickle to hemolyze is not true. And when it hemolyzes, it releases all its goodies. And the biggest thing is free heme, which is part of hemoglobin, but the free heme molecules, our body doesn't like them. So our body invented a scavenger to get rid of it, and that is called haptoglobin. So you'll often hear us talk about patients that don't have any haptoglobin. Once haptoglobin binds to free heme, you can't detect it. And in this case, the free heme is kind of running rampant, and the majority of sickle cell patients, you can't detect haptoglobin. So that's not weird, but a lot of people who aren't as familiar will look for haptoglobin as a sign of hemolysis, which it is, except that it's almost never present, so it's not useful. But the other thing all this free heme does is soak up all the available nitric oxide in the blood vessel. And we need nitric oxide. It's what helps control the vasoconstriction of our blood vessels. And so without enough free heme, we have more issues with that. Without enough nitric oxide, not free heme. The other thing you'll see here is arginine pictured. I leave it there because arginine is actually a nitric oxide donor. We're not going to talk about it right now, but it's one of the various molecules that we've looked at globally to see if we can decrease crisis by the use of arginine. And there's some new data coming out at ASH that I'll bring back about that. So important to note that the cells hemolyze long before they sickle. They release free heme, and the free heme itself damages the endothelium. Not only does it soak up the nitric oxide, but it brings in more neutrophils because your body almost detects it like infection. So another colleague of mine made this really good image that shows you sort of all the different problems or all the different ways that sickle cell red cells cause problems. So starting over here on the upper left quadrant, we know the red cell itself contains sickle hemoglobin, and that's the A circle is showing you how that hemoglobin polymerizes. And when it does that, it causes the cell to physically sickle. The more deoxygenated that red cell, the more it polymerizes. So in the oxygenated state, it doesn't sickle as much, but when you get deoxygenated, it does. The more sickling you have, the more likely they are to adhere to the endothelium and the neutrophils, and the more vaso-occlusion and painful crisis you get. Going back the other way, when you think about the hemolysis like we just talked about, you get significant endothelial dysfunction because of the nitric oxide depletion and because of the increased inflammation and damage it does to the inside of the blood vessel. All that free heme causes all that sterile inflammation. And as a result, we get what they call the inflammasome activation. That just means that there's lots of global inflammation. You get neutrophils, you get platelets, and you get more problems. And of course, the more neutrophils and more inflammation you get, the more blocked that road is and the more likely to get vaso-occlusion. So I like this diagram because it really shows you sort of the circular nature of the problems. So voxelotor or Oxbryta is one of the new drugs that we talk about. Before we talk about it, I'm going to remind you about something you may or may not have learned in biochemistry, which is how hemoglobin works, why hemoglobin's a cool molecule. Yep, you can see my heme nerd coming out. So hemoglobin is cool because it responds to the amount of oxygen in the environment. When there's low oxygen in the environment, so you have low PaO2, the hemoglobin releases its oxygen, and that's what should be happening in the tissues, right? Our body knows to release oxygen to the tissue to use. And then the hemoglobin in the red cell goes back to the lungs where there's a lot of oxygen and it reloads. So it's a really handy molecule in that way. If there's ways though we can shift it. So when we left shift it, we move this curve to the left. That makes it more likely that at low partial pressures of oxygen, it will hold that hemoglobin tighter. So a lot of what the molecules do right now, or are trying to do, is see if we left shift it so it doesn't release its oxygen right away, if that can sort of postpone the sickling. The problem is, you left shift it too much, it won't release its oxygen at all. So this drug, voxelotor, is actually a small molecule that binds to hemoglobin and changes the place at which it actually releases oxygen. So it left shifts it. And what that does is prevents additional sickling and prevents the polymerization of the hemoglobin, which does actually decrease the amount of sickling and hemolysis that happens. And the goal was, by doing that it would improve blood flow and modify the sickle cell course. Those things we don't see yet. We do see that it reduces hemolysis and improves anemia. So the drug is called voxelotor. We used to call it GBT 440. Its other name is Oxbryta. It's a once daily drug. And it really does decrease hemolysis and increase hemoglobin. The original study that was done looked at two main doses, 900 milligrams and 1500 milligrams, and had an interesting endpoint. The endpoint was the number of patients that got at least 1 gram over baseline hemoglobin. And the reason that's interesting is we don't actually know that just 1 gram of hemoglobin will make any clinical difference. But somehow they got the FDA to agree to this. And the reason was that pain, as we've sort of talked about, is so nebulous and so hard to measure that a lot of trials fail when we use pain as an endpoint. So they used hemoglobin. And they found that at the full dose, the 1500, about 2/3 of the patients did get that increased hemoglobin. And at 900, 1/3 did. The follow-up study to voxelotor showed us, and I don't have it on here, so I apologize. The follow-up study actually showed that it did do all these things, but while it improved hemoglobin, decreased new reticulocyte, and decreased bilirubin, it did not change pain crisis or how people felt. They didn't feel less fatigued or better. Some people did, but not enough to achieve statistical significance. The other new drug is focused on P-selectin. So what is P-selectin? P-selectin is a hook on the inside of the endothelium that hooks onto neutrophils. P-selectin is also on the outside of platelets for the same reason. It acts as a hook that kind of makes things stick together. And if you target it, you can decrease some of that intracellular adhesion. This is another way of looking at the selectins. There's more than just one. There's 3 main selectins: P-selectin, E-selectin, and L-selectin. But P-selectin is the main one that we focus on because it's what our drug uses. E-selectin is also important, however. E-selectin is just on the endothelium or inside of the blood vessel. It's not on the actual white blood cell or platelets. L-selectin, which we don't talk much about, is only on leukocytes or white cells. It's not on the endothelium at all, so we don't tend to target it. But P-selectin and E-selectin both play a role in that attachment of the neutrophil that allows it to get into your tissue to fight infection. In animal models of sickle cell, specifically the mouse, they found that if you blocked P-selectin, you could disrupt this pathway, and as a result, cells couldn't get in at this frequency. Further, you could actually stop sickling if you blocked it. Not the sickling itself, but stop the actual crisis. In other words, the cells would still sickle, but they wouldn't stick to the inside of the blood vessel. So the original study was called SUSTAIN. This is the study of crizanlizumab. We're not going to go through it too much, but we're going to talk about that the main goal was to decrease what they called SCPCs, or sickle cell pain crisis. Don't ask why they didn't call it VOC like everybody else. And then they wanted to make sure that you could decrease the crises if people were or were not taking hydroxyurea, and regardless of what type of sickle cell disease they had. They looked at 2 different doses, a 5 mg per kg dose and a 2.5 mg per kg dose. And they found the 5 mg per kg to be very effective, decreasing the number of crises by 47%. And they also found that it increased the time to first pain crisis. So once you started crizanlizumab, it took longer to have a crisis. These are what we call Kaplan-Meier curves that looked at that. And one thing we like to see when we study a drug is green here is placebo. Blue was the middle dose, or the 2.5 of the drug, and red was the drug. And we like to see a dose-dependent effect. So in other words, we like to see the blue does a little bit and red does more. That really gives us confidence that the drug does what it's supposed to do. And this graph specifically, again, is showing you the time to first event, showing you that from the time of study, you were less likely to have a crisis if you were getting the high dose red. This is what we call an odds ratio, or it's looking at the rate of things happening. And what's important is that all the red dots are on the left, showing you that they're more likely to happen than the blue dots to decrease crisis. So our thought of this all being about the red cell is no longer true, because if it was really all about the red blood cell, you wouldn't have seen this significant improvement in crisis that we see here just by the blocking of P-selectin. So it sort of tells us that if this cell sickles but doesn't stick, it is less likely to cause a crisis. So we're going to stop there. We're going to pick up on these new drugs and more information about them later. This was just talking about how they work for today. Any questions about that? All right. So we are going to follow up later talking about like what we know now about the new drugs and some more data on how they've been working in the real world. But for now, we'll just stop there and have a wonderful day. See you tomorrow.